Good morning, everyone. My name is Mandeep Singh, and I'm a professor in the Department of Cardiovascular Disease here at Mayo Clinic in Rochester. And it is my distinct honor and privilege to welcome Dr. Scott Wright, who not only is a friend but colleague for more than 2 decades, and has specialized and made his career in atherosclerotic cardiovascular disease with special reference to among patients who have diabetes as well. And that's what he's going to speak on today. He chairs our IRB, and he's a phenomenal researcher, not only a researcher, but a clinician as well. So welcome, Dr. Wright. Let's hear what you have to say.
Oh, thank you, Dr. Singh. And it's really my privilege to join you. Congratulations on a great podcast. I want to say hello to everyone and thanks for your interest in this topic. These are my disclosures, largely from the research work that I've done. These are the learning objectives. We want to talk about the new recommended LDL thresholds, newer therapies for treating people with type 2 diabetes, including new oral agents and the PCSK9 drugs. Look at some specific data on bempedoic acid and Inclisiran, and then talk about using all of these things. I think it's important to begin by pointing out that diabetes in and of itself is a much more aggressive disease in the cardiovascular system than patients without diabetes. This is work from Pedro Moreno many years ago, who's an interventional cardiologist from New York, looking at coronary plaques in patients who had atherectomy. He looked at the staining for atherosclerosis and inflammation in diabetic patients and non-diabetic patients. And what you can see on the left on your screen is that the diabetic patients had really intense staining for inflammatory macrophages. They had much greater accumulations of lipids. They had eccentric complex plaques, often with a very thin fibrous cap. And all of this really is why our patients with diabetes have more atherosclerotic cardiovascular events. It's part of the whole disease process. And if I can just say at the beginning, and I'll repeat this throughout the symposium, diabetes is more than a disease of glucose metabolism. It's more than high glucose. It's a disease of atherosclerotic cardiovascular disease. It's a disease of inflammation. It's really a multi-system disease that we have to address. And along those lines, hyperglycemia, which is often how we characterize diabetes, really promotes inflammation and atherosclerosis, whether it's initially with endothelial dysfunction, ultimately with the formation of fatty streaks, with the attraction of vascular smooth muscle cells into the subintimal space, with the proliferation of those cells and macrophages, and with the secretion of cytokines and other chemicals which weaken the fibrous cap and promote plaque rupture. And then once a complicated lesion forms, diabetes itself tends to promote further accumulation of macrophages, activation of T cells to a nasty state where they secrete cytokines to weaken the fibrous cap and ultimately cause it to rupture. And then, of course, there's the whole issue of thrombogenicity as well as hyperviscosity that accompanies diabetes. This was published a little over a decade ago now in a very nice review by Dr. Marks and colleagues from Germany. When we look at the lipids of our typical diabetic patients, we often see what I call a lipid phenotype. They have an elevated triglyceride level. Typically, it's above 150. So in this slide, I said 175 to 400. And frequently, it's 200, 250. Frequently, when they have poorly controlled diabetes, it's pushing above 350. They have accompanying lower HDL levels. It was not uncommon to see a diabetic with an HDL of 25, 28, or 30. And then they have moderately elevated to moderately, even a bit more than moderate elevations of LDL. So their LDLs are typically above 100, but below what we see with patients that have genetic dyslipidemia. So they typically run 100 to 160. And then when one measures the non-HDL cholesterol, and remember that's calculated by taking HDL, subtracting it from total cholesterol, and the non-HDL cholesterol is the total atherogenic burden. And in diabetic patients, this portion is quite elevated. And this is where the low HDL and high triglycerides synergize to really promote atherosclerosis. Remember, diabetes is also characterized frequently by abdominal obesity, elevated blood pressure. If they are smokers and have that classic risk factor, it's really a synergistic addition. It's more than what you would see with tobacco use alone. And so all of this leads to both macro and microvascular disease. And that's why we need to treat the lipids in particular, but also holistically treat diabetic patients. When we talk about treating diabetic dyslipidemia, I thought it would be good to cover what has worked to reduce risk and really what has not worked to reduce risk. Many times in clinical medicine, what seems intuitive or logical really is not. And what sometimes seems paradoxical works quite well, and that's why we do research. This was early data from the 4S trial. This was a trial conducted in the 1990s, and interestingly, 4,444 patients in Scandinavia who had very high lipid levels and had atherosclerotic cardiovascular disease. In the trial, they were randomized to placebo or simvastatin 40. And so it was very early days when we were still able to do placebo-controlled trials with statins. And the diabetic patients randomized to simvastatin had a 54% reduction in the primary endpoint compared to the non-diabetics, where there was a 32% risk reduction. And this was kind of the first hint that treating lipids in type 2 diabetic patients really reduced risks substantially. And if one looks, you can see there's a 22% absolute risk reduction, which would mean a number needed to treat of 4 to 5 to really help a diabetic patient with a statin drug. Further work and a number of clinical trials later, Rory Collins and his team from the Clinical Trials Unit at Oxford put together what is now referred to as the Cholesterol Treatment Trialist meta-analysis. And they looked at a variety of factors in a series of Lancet publications and an exceedingly large population of all patients who were treated in the placebo-controlled statin studies. And what he showed is that for every 1 millimole we reduce LDL in a type 2 diabetic patient, there's a 22% relative risk reduction and a 1.5% absolute risk reduction. And remember, most statins will reduce LDL cholesterol between 1 and 2 millimoles. The PCSK9 drugs, an additional 1 to 2 millimoles. And that's really the secret to understanding how we reduce risk in type 2 diabetic patients. Well, what about using medications like fibrates, which lower triglycerides but raise HDL? Given the diabetic lipid phenotype with a low HDL and a high triglyceride level, it would make sense to use a therapy which treats both of those conditions. And this is a really good example of where in medicine what seems obvious and intuitive just didn't work. When we look at probably the best clinical trial conducted with fibrates, the ACCORD trial, because in the ACCORD trial, every patient was treated with baseline or background statin therapy and then randomized to either fenofibrate or placebo. And many of us had high hopes with ACCORD that it would show risk reduction in diabetic patients, and it did not. There was no difference in the primary outcome, no difference in an expanded macrovascular outcome, surprisingly, no difference in overall mortality or death from any cause, and really no difference in death from cardiovascular disease. And this is consistent with almost every fibrate trial except the Helsinki heart study, which I think most of us have said is no longer valid or reproducible because of some trial characteristics with patients who were enrolled in it. So while we use fibrates to treat elevated triglycerides in our diabetic patients, we should do so understanding that we're just reducing their risk of gallbladder disease or pancreatitis, that we're really not going to reduce their long-term risks of cardiovascular disease with a fibrate. More recently, we've had PCSK9 therapies. Now, these are quite expensive agents, and most of you are probably not prescribing them. Dr. Singh and I use them a bit in our patients because we're seeing the highest risk populations. We have 2 large outcome trials which have specifically looked at whether PCSK9 treatment can improve outcomes in diabetics. Those trials are the Fourier trial using evolocumab or Repatha and the Odyssey outcome trial using alirocumab or Praluent. You're seeing much more evolocumab marketed today because the sponsor for alirocumab is just not marketing it. But the data is very similar and consistent between both of those studies. Here you can see Kaplan-Meier projections in the Fourier trial looking at the primary endpoint on top and the secondary endpoint on bottom. And then you can see the alirocumab Odyssey outcomes data put together by Koshray and Greg Schwartz and team showing about the same. And they both had about a 1.5 to 2% absolute risk reduction, or a relative risk reduction here of 16 to 20%. So the PCSK9 drugs in these studies were used on top of statins. So this is an additional benefit to what a statin would do. So to summarize where we have been, to date, therapies which lower LDL cholesterol improve outcomes in diabetic patients, and they reduce major adverse cardiovascular event rates. But therapies which lower triglycerides and raise HDL have really not shown any benefit, and that's true for niacin as well. So we've really struck out on the drugs that were tailor-designed for the diabetic dyslipidemia, but the old faithful LDL lowering therapy has worked. So we have a couple of new agents now that you probably have seen and maybe have seen used in a patient or two, which are available for us to use to treat dyslipidemia in diabetics as well as other patients. One is a medication called Bempedoic acid. It's a pill that's taken every day. The other is an injection called Inclisiran. It's given twice a year, much like a flu vaccine. It's a very small dose of a drug that's given infrequently. Now, Inclisiran I'll talk about first because I've done a fair amount of research with that and published maybe a couple dozen papers with it now. And it's a targeted therapy for the liver. It's a first-in-human, small interfering RNA. It's different than the COVID vaccines because the COVID vaccines use RNA to generate an immune reaction, while Inclisiran, as a double-stranded RNA, has been chemically modified not to cause any immune reaction, but to be taken up into the liver where it works through the RNA-induced silencing complex to stop the production of PCSK9 protein. And by lowering PCSK9 protein by about 80% in plasma, it reduces LDL cholesterol by about 50%. And to our knowledge, there's really no off-target binding of this medication to any other tissue because the receptor that Inclisiran binds to has over 500,000 copies of the receptor per liver cell or hepatocyte. So once you inject it, the liver just grabs onto it and sucks it in. So Inclisiran binds to a receptor called the ASGPR receptor. It's, like I said, on the surface of the liver almost exclusively. And it's got a carbohydrate attachment called N-acetylgalactose to the Inclisiran, which allows it to bind that receptor. It's brought into the liver cell in an endosome. And there the double-stranded RNA separate. The antisense strand is really locked into the RNA-induced silencing complex, where it's a complementary copy of the messenger RNA for the messenger RNA of PCSK9. So it's been chemically designed to mate with the messenger RNA for PCSK9. And once the RNA silencing complex sees that mating of the antisense strand of Inclisiran to the messenger RNA of PCSK9, it chops up or chews up the messenger RNA to make PCSK9, so the liver cell just doesn't create PCSK9. And that has an effect of lowering it by almost 80% in plasma. And by doing that, it really reduces LDL cholesterol. If any of you are old enough to remember the video game Pac-Man, this is exactly how the RNA silencing complex works. And you're going to hear a lot more about this mechanism of drug therapy going forward because there are medications now for hypertension and amyloidosis which use the RNA silencing complex. And there are several medications being developed for lipoprotein A doing the same mechanism. I think it's fairly exciting because now we have medications that can target an organ of interest where a disease process is managed, mitigated, or started without having to give a systemic medication. And this is how it works, and I've talked about that, so I'll go ahead and go through that. So this was one of the clinical trials that we did. This was actually an aggregate summary of 3 placebo-controlled trials, Orion 9, 10, and 11, where we pooled the LDL lowering, and we had 2 primary endpoints. The first was how low did LDL go in those treated with Inclisiran versus placebo by day 510, and that was 50.7, or I rounded up to 51%. And then what was the time averaged reduction over day 90 through day 540 of this 18-month placebo-controlled trial? And you can see there was also a 51% reduction, time averaged over that time period. So here, giving a medication only every 6 months resulted in a 50 to 51% reduction in LDL in a short trial, albeit 18 months, that was placebo-controlled. We also ask in this initial study, how likely is it that we can get our patients to new thresholds? that the guidelines recommend. And in type 2 diabetics, it's now really recommended for almost all diabetics. We take them to an LDL of 70. And for those who have had a recent coronary event or stent or bypass surgery, their target LDL, at least for the first 12 to 18 months, would be 55. Well, in the left, for either half of the slide in red, are those on placebo. And again, these were largely patients on statins. Some had ezetimibe. I think 4 to 6% had ezetimibe, and about 4% were statin intolerant patients. So of those on statins, 2/3 were on high-intensity, high-dose statins. So they were getting really good therapy. And you can see that with regard to the use of statin alone, only 70+% of patients could get to an LDL of 100. About 31% could get to an LDL of 31%. Less than 7% could get to an LDL of 55, and very few could get even lower. So that's what we see in clinical practice, that most of us in our offices and most institutions just are not reaching the new LDL threshold using statins alone. However, if Inclisiran was added to the therapy, you can see that with a threshold of 100, over 94% of patients could get there. An LDL of 70, about 87% of patients got there. And 3/4 of patients, or 74%, got to a threshold of 55. And if you're like me and you like to take the LDL even lower to try to clean up the plaque, about 30% of patients could get to an LDL of less than 25. So this was in the 18-month placebo-controlled trial. When we look at a much longer study called Orion 8, which was an open-label extension of all the patients in the placebo-controlled trials, we saw persistent LDL reductions in these patients. LDL was reduced consistently right at 50%. Now, this population included patients who had atherosclerotic cardiovascular disease and diabetes, as well as patients who were statin intolerant or had heterozygous FH. And indeed, if you had ASCVD, including diabetes, your reduction was over 50%. Now, if you had heterozygous FH, your reduction was a little less, about 42%. And this is very typical with PCSK9 treatment in the heterozygous FH patients because they start at extremely high LDL levels. So the percent reduction is slightly less than patients who are starting at, lower LDL levels of 100 to 130. I want to show just 2 safety slides if I can. Because this drug goes to the liver, we've done extensive liver evaluations using 2 methods. One is a broad-based definition of any acute or chronic drug-related hepatic disorder. And what you see in this slide on the left, this Kaplan-Meier projection, Inclisiran patients are in blue, placebo are in gray, and you can't tell them apart because there's no difference between Inclisiran and placebo. That is, that Inclisiran was not associated with any excess risk in the liver compared to placebo. And when one uses a specific target definition of an ALT greater than 3 times the upper limit of normal, that's a time when we would stop lipid therapy like a statin. In those who started with a normal ALT, Inclisiran had no differences in the rates of that compared to placebo. In fact, they were exceedingly low here, about 0.5%. So we felt Inclisiran was quite safe. When one looks at muscle events, because we're often asked, my patients ask me, does this new drug cause muscle pain? And I tell them, no, in fact, it doesn't. If you look on the left, the Kaplan-Meier curve shows you a definition of rhabdomyolysis or myopathy, and Inclisiran and placebo had the same rates. If you look on the right, at a rise in CK to more than 5 times the upper limit of normal, now this is specific muscle injury showing myositis, the placebo patients in gray had higher rates of that than the Inclisiran patients. Now, why did Inclisiran seem to protect our patients against muscle injury? Well, maybe it is a protective drug in the muscle, but I don't believe that. I think what likely happened is the Inclisiran patients were also getting their lipids measured elsewhere and probably stopped statins. And you can see in the baseline group, they were all on statins. So you can see the impact of statins on muscle enzyme levels, and Inclisiran is indeed safer than that baseline. When one asks, does Inclisiran lower LDL in type 2 diabetes patients like it does in those with normal glycemia or metabolic syndrome? We just published this paper a couple of months ago, and you can see here a little over a 50% reduction in LDL in the diabetic population. So yes, Inclisiran works just as well in diabetes and prediabetes as it does in patients without diabetes. Finally, I want to just show you some outcome data. Now, this data is patient-specific or patient-level data. We went through the Orion 9, 10, and 11 patient database and aggregated all of the reported events. So this was a pre-specified endpoint. It was not a post-hoc analysis, but this was a pre-planned, pre-specified endpoint. looking at only 3,000 patients in those three trials. 300 events were total in our major adverse cardiovascular event. And we used a 5-point MACE, including pooled cardiac death, cardiac arrest, non-fatal myocardial infarction, fatal stroke, and non-fatal stroke. So a 5-endpoint MACE. And what you see are Inclisiran patients in red, placebo patients in sort of the navy or black color, and there were fewer MACE events in those treated with Inclisiran compared to placebo. And that looked at a risk reduction of 25% with a highly significant p-value of 0.013. Now, there are 3 large outcome trials still ongoing with Inclisiran, but I feel this outcome data is quite reassuring that lowering LDL with Inclisiran will reduce events and is certainly quite safe. Well, let's move on to a medicine that's given every day, not every 6 months. That's Bempedoic acid, and it's an oral pill that actually works similar to statins because it blocks the synthesis of cholesterol, but it works at a different part of that enzyme process. We all remember, where the statins work, but Bempedoic acid works upstream, and it inhibits ATP citrate lyase, so it prevents the biosynthesis of 3-hydroxy-3-methylglutaril. And that is then, of course, the compound that goes into the reductase step where statins work. And it's been tested in statin-intolerant patients. Steve Nissen and his team from C5, along with Steve Nichols from Australia, evaluated this. And you can see that they looked at a number of endpoints. And in each of these endpoints, whether it was a triple MACE endpoint, a quadruple, or a 5-endpoint MACE, they had about a 13 to 15% risk reduction. And that really reflects the modest degree of lipid lowering. And here you can see that Bempedoic acid lowers LDL about 16 to 18%. That's, roughly a half a millimole. And so they're getting, not quite 22% risk reduction, but they're getting exactly what one would predict from the degree of LDL lowering. And I've shown you the Kaplan-Meier curves on the right. Now, one interesting twist with Bempedoic acid that I like is that it also reduces C-reactive protein because inflammation is important. So it seems to be a drug similar to statins in that it lowers inflammation and lowers LDL, but it's much weaker. It's very similar to ezetimibe. More so than a statin. So it's a drug that you can consider in your statin-intolerant patients. Well, let me just say in summary, if I may, that with regard to type 2 diabetes, these patients benefit from aggressive LDL lowering with all of the available therapies. Our new targets are 70 in patients who have uncomplicated diabetes or diabetes over 10 years duration, and less than 55 in those who've had a recent acute coronary syndrome or unstable heart disease of any type. We have 2 new therapies available today, Inclisiran as an injectable every 6 months, Bempedoic acid given daily as a pill. Both of them are safe. Both of them work to reduce LDL. Both of them will reduce events. Inclisiran is a new and novel PCSK9 therapy whose main advantages really are it doesn't really have any major side effects except some itchiness at the site of the injection, and it can be given twice yearly. And patients who get it really like that aspect of it, and they get a sustained lowering. So if they forget to take their oral medications for several days, they still have a 50% reduction in LDL, so they're protected, and it improves adherence. And I haven't shown you data, but among all of the PCSK9 drugs, alirocumab, evolocumab, and Inclisiran has the highest 6 months and 1 year adherence. Over 90% of patients are still on it at 1 year compared to less than 60% of patients with evolocumab and alirocumab. For those of you who have patients that only want oral medication, Bempedoic acid is an excellent choice. It can be used as an alternative to statins. It can be added to statins. Typically, it's used in combination with ezetimibe to try to, each of them giving you a 15 to 20% reduction. So together, you can get about a 40% reduction in LDL. But by itself, it only reduces LDL 15 to 20%. And finally, let me just summarize and say one point, if I may. We have to treat dyslipidemia in diabetic patients, but it's also important to remember that the treatment of diabetes, the management of the risks in diabetes involves a multifaceted, holistic approach. We need to also work on lifestyle modification with exercise. We need to work on their blood pressure to keep it well controlled. They need to try to lose weight, and with the new GLP-1 drugs, almost every diabetic patient can get to a normal body mass index. It's still important to maintain good glycemic control, and as Dr. Singh and his research has shown, it's really important to keep them exercising and active because frailty is the ultimate end pathway, and if we don't prevent the frailty, they'll die prematurely. So reducing cardiovascular risk in type 2 diabetes requires a multifactorial approach, of which controlling dyslipidemia is one important aspect, but not the only one. Well, Dr. Singh, I hope this has been helpful and not too long this morning.
Oh, uh, I think the viewers will agree this was one of the best presentations we've had so far in the last 5 years of our being doing this podcast. And I thank you so much for sharing your expertise. Before the questions, the readers think about questions, let me ask you, a lot of attention has been targeted on complementing or synergizing the treatment on inflammation with cancunimab, with colchicine, and you showed the first slide, which clearly, in diabetics you have very high degree of inflammation as well. So do you know whether this combination works or would work? What are the drugs in the pipeline, do you think, that will target specifically the inflammatory pathway?
That's a really good set of questions. I do think it's important to target the inflammatory pathway. I think statins do an excellent job of that and have good outcome data. The data with colchicine is somewhat limited because it has no pharmaceutical or government funding behind it. Jean-Claude Tardif and others have really done these studies on a wing and a prayer, so to speak, and paid for them out of their own research funds, and they've shown excellent data. So I do use low-dose colchicine in many of my patients post-ACS who can tolerate it. But I think, like you probably have seen too, many of our patients have GI side effects, so keeping everyone compliant to colchicine can be challenging. Even though the data from Colcat and others show good tolerance, it's not been my observation. I asked Paul Ridker recently if he knew of any new therapies targeting inflammation. He said he couldn't really discuss it at length, but there are some in the pipeline. And so I think there probably will be that promise. Canakinumab was so expensive that it was impractical, right? It was going to have to be sold at, a 5 or 6 figure price level, that it was deemed not to be suitable for treating ACS because the health outcomes research wouldn't support selling a drug at 50 or 100,000. So colchicine's a lovely alternative, and statins are as well. And I think now we also have bempedoic acid, which lowers TRP. So I think it's important to choose wisely. I also have found, maybe you have too, that mitigating risk factors, including obesity, smoking, also can lower inflammation. And so those are sort of non-pharmacologic or non-lipid-based approaches to also hitting inflammation.
Right. That's great. The second question I have is there is a lot of talk and recently presented study on Lp(a), targeting that molecule along with the generic lipids, especially in patients who have diabetes. Do you have any experience, or what is your strategy on those patients?
Prior to the last year or two, my strategy had been to take their LDL as low as possible with a statin. But the more I read and learn, the more I realize, because data have now been published from a UK Biobank analysis, that statins just don't help across quartiles or tertiles of elevated lipoprotein A. We're just not reducing the risk like we thought. But it turns out that PCSK9 drugs do reduce the risk. There have been really elegant studies. Vera Bittner published one from Odyssey Outcomes, and I think Mark Sabatine or Sabina Murphy published one from Fourier, looking at the absolute and relative risk reductions in patients with an elevated LPA versus not, who were on their PCSK9 drugs. And there was a much greater relative and absolute risk reduction, showing that really now for people with an elevated lipoprotein A, we should be using PCSK9 therapies. So all of the PCSK9 drugs that are on the market, alirocumab, evolocumab, and Inclisiran, lower lipoprotein A 25%. We have not analyzed any outcome data with Inclisiran because we're waiting on the very large outcome trials to finish, and then we will. And at the same time, we will see new therapies which treat lipoprotein A. There's a small interfering RNA from Amgen that lowers it almost 100%. Novartis has a an antisense oligonucleotide, which works through a similar mechanism that lowers it 70-80%. There's a Lilly compound that's oral that lowers it 50, and then there are injectable compounds that lower it. So I think given another 3 years, we're going to have additional tools to lower lipoprotein A, and we'll also have data on the synergism of lowering LDL and lipoprotein A simultaneously versus either alone. So we've waited our entire careers for this, Mandeep, and I think we're going to have that data in about 3 years.
So if a patient with diabetes comes to you, say we treat ACS patients, for example, and you how do you strategize how you want to add therapy, especially as it relates to lipid lowering? So do you then start with statins, maximize it, and then start adding, for example, Zetia, and then if that also doesn't do it, when does the PCSK9 come into your protocol? And also, how many in your practice do you see patients who are lipid or statin intolerant that you take them into PCSK9? And the last question I have is, how is the cost affecting the treatment and adherence of this expensive therapy?
Well, those are 3 great questions. Let me see if I can unpack them a little bit for our webcast participants and ourselves as well. I think about 20 to 30% of the population has some form of statin intolerance. Some of it is a perceived statin intolerance, but I'm seeing at least 5 to 10% of patients, many physicians, who have profound muscle symptoms, and they are extremely worried about their health, but they cannot tolerate a statin. So it's a very common entity, and I'm getting a lot of now referrals from within our own practice of physicians with statin intolerance who want to try Inclisiran for that reason. Let me start with the first question, if I may. When I see a patient with diabetes, if I'm treating them in hospital, I ask our medical team, typically it will be either an NP, PA, or some residents and fellows, what's our target LDL? And frequently I'll say, well, I'd like it, below 55. And if I can get it even lower, I will. And if they come in with an LDL of, say, 120, 130, I know that, statin alone will not get them to where they need to be, nor will statin plus ezetimibe. So my ideal is to start them on 20 or 40 of rosuvastatin or atorvastatin. I don't usually start with 80 of atorva because, number one, it's not FDA approved to start. Number two, it causes a lot of muscle aches. So, but you get 90%.
But you've seen that, right? So that's the thing that worries me as an interventional cardio. We put a stent and we start 80 of Lipitor. That's not the right thing to do.
No,
right?
it's not the right thing. They come back with muscle pains, and they
So
want
you
to
start
stay on
40
it.
then.
I do. I start with 40. And then I say, look, the difference, if you look at where your LDL is going to fall with 40 of Lipitor or atorvastatin, it's only going to be 6 milligrams lower if you go to 80. But you avoid a lot of those muscle aches and pains.
That's a good point.
Patients stay on it. But I calculate how much of a reduction do I need? And if they need a 70, 80% reduction, I know we're going to have to go to PCSK9. So I try to prescribe it by hospital discharge. I would love to be able to give them a PCSK9 in hospital because I think that acute lowering is important. When I see them in the outpatient, we investigate with their insurance whether it will cover PCSK9. Many times I have to step them through statin with ezetimibe, so see them back one extra visit to show their LDL is not at goal, and then we add the PCSK9. I give my patients a choice. I say, we actually have 3 wonderful PCSK9 drugs. 2 you give at home yourself every 2 weeks, and they both are safe and effective. And then 1 you need to come in every 6 months to the office or to an infusion center and get an injection every 6 months. I would say 80 to 90% choose the every 6-month route because they don't want the self-injection of every 2 weeks. They don't want the hassles. And a recent analysis using the Commodore registry showed that under 50% of people on Repatha are compliant at 6 months, while 70+% on Inclisiran are. And if you look at a year, it's 90% with Inclisiran. So I think our patients are telling us that taking it every 2 weeks is hard to remember. It's a bit of a hassle. They're afraid of injections, right? Now, the drugs are expensive. When Repatha and Praluent, alirocumab and evolocumab came out, they were priced at about $14,000 a year. which was way too much, and no one could get coverage for them. Here we had life-saving therapy, we couldn't afford it.
Right.
Then they dropped it by half, and then once Inclisiran hit the market, those drugs went down in cost again. So they cost patients $3,000 to $4,000 typically. It's hard to really know because health systems get rebates, so you don't really know how much they're truly costing. And their insurance typically will cover it 70-80%. Inclisiran, on the other hand, because it has to be given in a doctor's office or an infusion center, for Medicare patients is covered under Part B, which means that 80% is paid for by Medicare, and supplemental insurance covers a good portion of the other 20%. For privately insured patients, there are times that it's a struggle because you have to write a letter of appeal, and sometimes they approve, sometimes they don't. But there are centers that give Inclisiran outside of doctors' offices or providers' offices all around the U.S., and so it's not really been a problem. They have to find a place for our patients to get the injections. They don't always have to come here. Many of my patients elect to come back here. And I know our colleagues in Arizona and Florida are using the same mechanism. I think the Mayo Clinic Clare site they're giving the injections in their office because this really is like a flu shot. It's just a tiny syringe. You give it, you pull it away. You don't have to have blood pressure or vital sign monitoring afterwards.
That's good to know. That's good to know. Do you worry about glycemic control with statins in patients who have diabetes?
I worry really about precipitating diabetes in patients who are pre-diabetic. You know, the person with the BMI of 33 whose triglycerides are high and their glucose is 110, 108, you know, and you just know if you put them on anything above 20 of Atorva or 10 of Rasuva, they have a higher risk of developing type 2 diabetes. So yeah, so I think in those patients, it's one ideal strategy is to use a lower dose of statin and then add a PCSK9 drug, because you're going to get about the same LDL lowering whether you're on 10 of Atorva or 40 of Atorva if you're using Repatha, Praluent, or Inclisiran.
So these are patients who do not have CAD, or do they have CAD?
Either way.
So even for primary prevention.
Yes. Yes, I think we have to be aware. You know, we have to caution our patients that there is a risk of the diabetes being precipitated. Now, the studies have shown that the benefit and risk reduction from the statin offsets the onset of diabetes, but I would much rather, in those patients, for example, throttle back the dose of the statin, get them on a GLP-1 drug and metformin, try to get weight down, maybe even prevent the onset of diabetes. And by doing that, we also can improve their lipid profile.
There was a recent article where they showed that the incident diabetes with GLP-1 goes down by almost 80% with weight reduction. And I think complementing that with PCSK9, I think would be hugely beneficial,
Yes.
especially to patients who are at risk of developing CAD.
Yes.
With the last slide that you have on, all these patients not only just have diabetes, but have conglomerate of risk factors that put them at a very high risk for having a CAD. How about CHIP? Do you have any therapies? Now, CHIP, we all know, I think readers may also know, is are the cells, the hematopoietic cells, which then circulate in blood. These patients have very high risk of developing cancer, but then they recently found that there is high risk of development of athero in them as well. Do you have you worked on that aspect?
I haven't worked on that aspect. It's an interesting field.
Yeah.
I know that all three of the PCSK9 drugs have had to report to the regulators, EMA, FDA, UK, and others, the risks of new cancers, and there's no increase in risk. But again, if you're looking at a favorable or unfavorable impact on CHIP, it might take a decade to see, and so we just won't know that for a while.
Right. So, what are the new drugs in horizon, in your opinion? Is Inclisiran or other PCSK9, are they the last mile in this marathon, or do you think we have other targets to reduce atherosclerosis?
I think there are still plenty of good targets and plenty of things in the pipeline. There's another PCSK9 drug that a small team from Cincinnati, Ohio, and Charleston, South Carolina are developing. It's once a month. It can be stored more easily than, say, Praluent or evolocumab. and they think it has a huge potential in the third world. It's got really good, strong LDL lowering, 60, 65, 70%. And I think that it's once a month. It'll give the every 2-week injectables serious competition once it's approved. There's an oral PCSK9 drug that's coming out. I'm not optimistic that it will have huge uptake, because why do you want to take a pill every day if you can get an injection twice a year with Inclisiran, or less free, or even monthly or every 2 weeks instead of a daily medicine?
Right.
I think the lipoprotein A drugs will have a huge impact in those patients, like my own mother, for example, who had an elevated lipoprotein A and had a myocardial infarction in her 60s. So that will be a therapy. And then we have drugs that lower triglycerides that will be injectables, whether it's familial hypertriglyceridemia or those challenging triglyceride patients. And there are at
Any
least 2 drugs.
comparisons that have been done with different PCSK9 inhibitors head-to-head?
Head-to-head, in Orion 8, we did a run-in trial as a safety study. With Orion 8, we did a small arm with 100 patients or 200 who were on evolocumab for a year, and then switched them to Inclisiran to look for safety and tolerability. And if one looks at the LDL lowering in that population, it was about 60% with evolocumab, 55 to 60. And then once they switched to Inclisiran, they went down to almost the same amount, and then they came back up to 50. So I think in all fairness, we didn't do the statistics on that because we didn't have the precise data to do it. But the monoclonals are probably slightly more effective than Inclisiran. The trade-off is you take it every 2 weeks versus twice a year.
That's true. That's true. One last question I have is in primary prevention. So the latest guidelines do mention moderate reduction in LDL in patients who do not have, say, for example, risk enhancers or have CAD. So how is there a role of a cardiac CT when you think about the intensity of statin amongst patients who have diabetes and nothing else?
Sure. I think so. I think our patients want to know if they have disease. I think they want to know if they are at risk of a myocardial infarction or a stroke. And so I routinely look for signs of atherosclerosis, whether it's a coronary calcium scan or I like the CTAs now because you also can see where the plaque is and you can show them the plaque.
Right.
And I couple that with carotid ultrasonography, and then we know. And I don't do them all the time, but I do them, at least once a decade in my patients with diabetes that I see periodically. Most of the time we uncover disease, and that, of course, then creates an even lower threshold that we treat the LDL and that we intensify other preventive therapies. I think, what is the end goal here, right? I think the end goal for me is to try to help people stay alive and as healthy as they can for as long as they can. And if we want to do that, we have to say to ourselves, what causes premature mortality? Well, it's cardiovascular disease, it's stroke, it's cancer. And I think we have to screen for those and mitigate those as best we can through a combination of lifestyle, exercise, behavioral modification, and appropriate pharmacologic therapy to lower the risks for each of those. I don't get so caught up in the cost-benefit analysis that the Preventive Task Force does because I'm not responsible for the global budget of the U.S. for healthcare. I'm only responsible for my individual patients, and I'm their advocate.
Very true. Very true.
And I think the day is coming. It's very possible that there will be a successor to Inclisiran. I don't have any inside knowledge about this, but I can see a once-a-year small interfering RNA to lower LDL. Inclisiran, if you gave it once a year, it would be off-label, and I do not endorse that. But it's a 35% reduction in LDL, which is as good as you get with most statins.
Right.
If you factor in compliance, it may be better than most statins. And I think a more potent Inclisiran can be designed and manufactured that would give a 40 to 50% reduction with once-a-year injections. I think making therapies really easy and very convenient are the key. And I think recently I spoke in another country, and the CEO of a hospital and a cardiologist said, remember this. The lower you take LDL for the longer you keep it low, starting at the earliest possible age, is the best benefit for the patient.
Right. I mean, starting like in teens and early 20s, right? I mean, that's how early we want to go.
It is.
Right.
Yeah, because we know from the Korean War study that many U.S. Army veterans had severe plaques and they could have had fatal ACS. These are young soldiers who died either by combat or by suicide. And when they looked at the hearts and did autopsies, they were shocked at how much disease existed. Now, I think the population today is healthier than it was in the 50s. We have less smoking, but it's offset by other things, obesity and vaping and other things. So I think plaque is real. And we both have treated young patients with myocardial infarction in their 30s. So I think it would have been nice to have started their prevention therapy in the 20s or teens.
Yeah. Why do you think that the triglyceride low HDL targeting didn't work?
I think it's because they are a reflection of a couple of things. One is the degree of hepatic fat or steatosis that you have. HDL seems to correlate nicely with that. So I look at low HDL as a marker of hepatic fat, and it's the check engine light on the body. That means this patient has a problem, metabolic problem we need to correct. I think the elevated triglycerides reflect the body struggles with dysglycemia, right? Many of our patients who are going to develop diabetes, if you go back and look at their labs for 5 or 10 years before they develop it, they had elevated triglycerides. So the body is it's like with a ship taking on water. They have two spots where the water's coming in. So they're bailing the water out to keep the glucose down, but they're letting the triglyceride level rise as a consequence. And I think that reflects the dysregulation within the body. And I think the therapies were treating the wrong targets. They were treating the symptoms, but not the disease itself. And the disease itself was poor glycemic control, obesity, hepatic fat, lack of exercise.
20, 25 years ago, they were targeting this triglyceride so aggressively with gemfibrozole or any fibrates, and then niacin, and then that also got into hot water. And then we always learned that 1 point elevation of HDL reduces your CAD risk by 3%. That used to be the teaching, but you are saying that elevating HDL, most South Asians have this metabolic syndrome. We have very low HDL, very high triglycerides. But then that also affects how you calculate your LDL. So your thought is that if patients have low HDL, high triglycerides, target the LDL, but not the HDL and the triglycerides.
That's right. That's right. Here's why. I'm very concerned about our South Asian patients, and my own personal physiology is similar to South Asian patients. So there's a strong ethnic cohort also out of Europe that has the same cohort, the same physiology as South Asians, for example. I think low HDL is a reflection that the HDL gets loaded with triglycerides to try to get rid of body fat. And because it then becomes smaller, you can excrete it through the urine. It's not like you don't have HDL, it's that you're urinating it all away, as opposed to more larger, fluffier HDL can't be filtered through the glomerulus, so it hangs around to do reverse cholesterol transport. And so you need to target the elevated triglycerides with lifestyle, metabolic control, and with medication. I have no concerns about using fenofibrate in patients who have elevated triglycerides, but I also try to correct the underlying metabolism that's led to that. If it's genetics, it's genetics. And right now we have fenofibrate. 5 years from now, we'll have even better medications that are injectable once or twice a month, or even less frequent than that, to target those things. So raising HDL in and of itself with medication has not worked, but raising HDL with weight loss, with exercise, has worked. And I think that's because it's targeting the fundamental mechanisms that cause lower HDL.
That's a very important point. And one last question I have is subfractionation of lipids. Do you do that in your practice?
I find it fascinating. It's fallen out of favor. I think it helps me understand the metabolism and the just what the patient's struggling with. So I do it rarely. And it's like ceramides. Ceramides are probably more helpful than that because it gives you an actual risk of plaque rupture.
Right. But you don't routinely do.
Not routinely.
Right.
I find it fascinating. I'm interested in it, but it's just not routinely being used. Okay. It's like ApoB. ApoB is a great marker of risk, but not many people are measuring it. By the way, in the patients with high triglycerides, you're right. LDL is looking lower than it truly is, so I use the non-HDL component for my target.
That's important.
So what you do is you just add 30 to what the LDL target is. So if the LDL target's 55, then it's 85. If it's 70, it's 100 for non-HDL. And if it's 100 for LDL, it's 130 for non-HDL. So that's an easy rule of thumb.
Very, very important point. Thank you, Dr. Wright, for joining us this morning, and I can't thank you enough.
My pleasure. Thank you for having me.
Have a great day, guys. Bye-bye now.
Bye-bye.